taking
So
initiative,
happy for
like,
that.
yeah.
And Rohan is like
And
sitting with two laptops over there.
I
Bro,
can see
he's
that.
one man too, dude. I love it. I get like a message from him every second day, and he's like, "Can we do this? Can we do that?" And I'm like, "Definitely go ahead, man." Like, I'm so happy about all of this. It's damn nice.
Yeah,
I get a
I'm so
message
happy.
every 2 hours, I think.
That's good only.
Oh my God, once I get my next month's stipend, I'm like taking you guys out, okay?
You're the best co-president ever. We've had one.
Yeah, it's
She's
it's just
going to kill
because
you.
it's just because Pritik is oh,
Who didn't have you today? Similar faces. Nice.
Can anyone confirm me, is the live stream started and is the waiting slide visible?
Let me just check. I'll check it on my phone.
Yes.
Yeah, it has started.
So is there any audio being heard, like what we are talking, or it's just a plain slide?
The audio is also being.
Audio is?
Yeah, the audio is being heard. There's a slight lag.
So now?
Just a second.
So now?
Yeah, perfect. Just a second. Yeah, Mani, I think you can start now.
Okay.
Sorry for the interruption.
No problem. Good evening, everyone. This is Manini, Vice President, SRC BMCRI. Today we have with us on the call Pritik sir, our President of SRC BMCRI, Prerna ma'am, our Co-President, and we'll have three juniors presenting a topic. The topic of the paper being discussed today is assessment of vitamin D status in type 1 diabetes mellitus in pediatric age group. Our moderator is Nithya ma'am. And yes, let's begin. Over to Rohan, Vivekhan, and Malavika.
Thank you, ma'am, for joining us today. Just like a small clarification, would you want to discuss it with various parts, like after introduction, a few discussions, after the materials, methods, statistics, as well as the discussion, or do you want to do your parts like completely at the end? It's based on however you're comfortable, ma'am.
I think I'll come in whenever required. Nothing hard and fast rule for me.
All right, ma'am. Thank you.
Hello, am I audible?
Hello.
Yeah, thank you. Yeah, thank you so much.
Yeah, Rohan, you can begin. Malvika, Rohan, and Vivekhan, you can start.
A very good evening to one and all. I'm Vivekhan, and I will be presenting the introduction.
A very good evening to everyone present here. I'd like to thank everyone for joining, and I'm Malavika from first year.
Hello everyone, this is Rohan Dubeer. I'll be presenting the discussion and conclusion of this research paper. Thank you.
Okay, so let's begin.
Yes, Vivekhan. Begin.
This research was conducted by a group of professors from Navodaya Medical College in Karnataka. The authors of this paper are Pallavi Ashrit, Vishal Kaleska, Srinivasa Rao, and Harishbhat K. So talking about the abstract, diabetes mellitus is one of the most common diseases seen all over the world, particularly in India, where we find a lot of patients affected by diabetes. Type 1 diabetes mellitus is not that common, but then it is seen in a significant amount of people in India because our population size is huge. Type 1 diabetes mellitus is a result of an autoimmune disease where there is destruction of beta cells leading to insulin deficiency. And vitamin D deficiency may have a role in the development of type 1 diabetes mellitus. The parameters used to conduct the study were fasting blood sugar (FBS), postprandial blood sugar (PPBS), hemoglobin A1C or HbA1c, and vitamin D levels in children with type 1 diabetes mellitus. 50 healthy controls and 50 previously diagnosed type 1 diabetes mellitus cases of both sexes in the age group of 6 to 15 years were used for the research, and they were matched based on the sex and the age. In type 1 diabetes mellitus cases, it was found that the vitamin D3 levels were decreased, but fasting blood sugar, postprandial blood sugar, and the HbA1c levels were increased. The p-value was less than 0.01, which indicates that there was a highly significant negative correlation between the sugar levels and the vitamin levels. Thus, it seems like the vitamin D deficiency was prevalent in children affected with type 1 diabetes mellitus. So let's start with the introduction. Diabetes mellitus is a group of disorders which is mainly characterized by hyperglycemia, and it is of two types, type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 diabetes mellitus is due to insulin deficiency. As I had already told, it is mainly due to autoimmune disorder in which antibodies are produced against beta cells of pancreas. This leads to a decrease in the production of insulin. Thus, there is hyperglycemia seen. Whereas in type 2 diabetes mellitus, resistance against insulin is developed in certain tissues like liver, skeletal muscle, and in adipose tissues as well. This leads to hyperglycemia. So hyperglycemia is seen both in type 1 and type 2. Just the cause differs in both of these types. And hyperglycemia, if not treated, it can further lead to several complications. Let's take a look at some of the complications. So some of the initial microvascular complications would include retinopathy, which may further lead to blindness, nephropathy, which may lead to kidney damage, and neuropathy. Other macrovascular complications would include cerebrovascular disease, cardiomegaly or heart attack, and diabetic foot infections. In severe cases, blindness, renal failure, and lower extreme amputations are also seen. The factors which facilitate type 1 diabetes mellitus are mainly genetic susceptibility and non-genetic factors. Non-genetic factors include viral infections, toxic chemicals, and deficiency of vitamin D. In this presentation, I will be mainly addressing about the deficiency of vitamin D. One important thing to note is that hyperglycemia develops when more than 70 to 90% of insulin-producing beta cells are damaged. The earlier study, what we can infer from the earlier studies are that in certain countries like Finland, there is a high prevalence or high incident rate of type 1 diabetes mellitus. that is around 30 to 40 cases per lakh children in Finland. And in some countries like Japan and China, it can be as low as 1 in 1 lakh population. From India, there is very little data available, but a study from Madras suggests that it is present in Indian children at a frequency of 10.5 per lakh patient years, which is roughly around 0.26 per thousand population. I will next be discussing.
Vivekhan, can I just stop you there for a small thing? Can you just go to the previous slide?
Yes, sir.
So when you talk about incidences in general, when you are referring to any articles, what you've presented is what the paper has done. But when you standardize ratios and standardize data, you always compare them to what has been issued by a global organization. So you should have been a little more, if you wanted to go a step further, saying that this is what the paper states according to their references, but according to, let's say, the WHO, the Global Burden of Diseases, or the ICMR, they state that the ratio or the incidence of prevalence.
Sorry, Pratik.
Yeah.
Hello. Yes, coming to sources, like you were saying, the Indian government every year does a census on this.
Correct. So there's the
National
SRS
Family Health Studies or something like that.
Yeah,
so you
NFHS,
get data from the website
NFHS,
only, like the government website.
So you do have NFHS 4 and 5, which are currently put out. So you can follow the NFHS guidelines and you can see how much is the incidence and prevalence. But either which way, no matter what organization it is, you have to state a standard reference that this was where it was originated or picked up from. Because look, although we trust global data a little more, but our Indian data is what we practically follow. We make guidelines based on the Indian data. So that is one thing.
Sir.
And second is, when you say there is very little data from India, that is not possible with respect to diabetes. Like, even if the paper states that in India, the research on diabetes is done a lot and has been going on, and there's still so much more to explore, that statement would be like incomplete. You can say that the paper states it, but however, there is data which states, or there is another article which references or goes against or for this. So that would be a little better way of you trying to tell us what you have inferred from the entire introduction.
Yes, sir. Actually, it's related to type 1 diabetes mellitus. So, yeah, that's why there is not that much data available. When it comes to type 2 diabetes mellitus, a lot of researches were done.
All right. No problem. No problem.
Move on.
Yeah, you can go ahead.
Yes. Okay. So vitamin D is a fat-soluble vitamin, and structurally it's very similar to sterols. The structure given on the left represents vitamin D, whereas the structure given on the right represents a sterol. The functioning of functioning of a vitamin D molecule resembles to that of a steroid hormone, which exerts its action after entering the nucleus. Sources of getting vitamin D include the major direct source, that's the sunlight. From UVB rays, cutaneous synthesis happens. Other sources include food items like fatty fishes and vitamin D supplementations as well. Talking about the synthesis and the activation of vitamin D, from 7-dehydrocholesterol, which is the provitamin, vitamin D3 is synthesized. And from vitamin D3 is actually inactive, so it undergoes two hydroxylation steps in order to form a active vitamin. So from vitamin D3 in liver, it gets converted into 25-hydroxy vitamin D by the enzyme cytochrome P450 to R1, and this substance goes to the kidney, that gets converted into 1,25 dihydroxy vitamin D by the enzyme cytochrome P450 27B1. So cytochrome P452R1 is also addressed as 25 hydroxylase, where the hydroxy group is added at the 25 position, whereas it is further converted into dihydroxy molecule, where one more hydroxyl group is added at the first position. Vitamin D further binds to vitamin B binding proteins and gets circulated. Once it reaches a designated cell, the vitamin D binds to vitamin D receptor and then exerts its action. So This represents the active form of vitamin D, which is bound to vitamin D binding protein, and then it enters the cell with the help of megalin, which is a endocytic receptor, and then it binds to the vitamin D receptor in the nucleus. The major circulating form of vitamin D is 25-hydroxy vitamin D3, which can also be called as calcidiol. It is the major circulating form and it is a storage form. But the active form is 1,25 dihydroxy vitamin D, which is the active form, which is the functions of vitamin D are mainly attributed to this active form. The gene for VDR and cytochrome P450 27B1 genes are found in chromosome number 12, and mutations in cytochrome P450 27B1 gene can cause vitamin D dependent rickets, and polymorphisms of the same gene are associated with type 1 diabetes, Addison's disease, Graves' disease, and Hashimoto's thyroiditis. Earlier we had spoken about the factors which can promote which can lead to type 1 diabetes mellitus, and the genetic factor is because of this reason that cytochrome P450 27B1 promoter of this gene is often transmitted to offspring with diabetes type 1 diabetes mellitus. That is, a parent who already has type 1 diabetes can pass it to their offsprings by transmitting this promoter. Talking about the immune mechanism, about how type 1 diabetes mellitus is formed and how vitamin D deficiency can be one of the major causes. We already know that beta cells of pancreas are destroyed by immune system in type 1 diabetes mellitus, and vitamin D receptor is detected in almost all cells of the immune system, especially in antigen presenting cells like macrophages, dendritic cells, and activated T cells. This led to an investigation in which scientists studied about vitamin D receptors and beta cells of pancreas, how these immune cells can affect beta cells of pancreas, and how vitamin D is related to these immune cells. So basically, vitamin D over here is bound to vitamin D receptors in the nucleus, and then vitamin D causes a decrease in the production of interleukin 2, interferon gamma, and tumor necrosis factor alpha. When the production of these substances are decreased, the production of type 1 T helper cells also decreases. Now, why these type 1 T helper cells are required is because these cells mainly, T helper cells mainly, cause the destruction of beta cells in pancreas, which ultimately lead to insulin deficiency. So, if vitamin D can inhibit the production of these substances, then automatically helper T cells production will also be inhibited, thereby leading to normal control of glucose levels. Though I have specifically told only about type 1 helper cells or helper T cells, there can be other immune cells also, and the mechanism remains the same as shown in this picture. HbA1c or glycated hemoglobin. So glycated hemoglobin is formed when the glucose levels in the blood are high and the glucose molecules enter the hemoglobin. So what we see in the picture is the hemoglobin is attached to certain glucose molecules. And when there is a high HbA1c level, it indicates that the blood glucose level is more. When there is low HbA1c level, it indicates that the blood glucose level is less. The normal value of HbA1c remains around 5 to 6%. But yes, anything above 7, we generally say that it can lead to diabetes. The most common form of glycated hemoglobin is HbA1c. There can be other forms as well. Several clinical trials in type 1 diabetes mellitus have shown that achieving glycemic control significantly decreases the microvascular complications of diabetes. So what this states is that if we can get a significant control over our blood glucose level, then the complications which I had discussed before, the possibility of the patient getting those complications would decrease. So basically, with every 1% reduction in HbA1c level, there can be about 37% decrease in risk for microvascular complications and 21% decrease in the risk of any endpoint or death related to diabetes. The aim of this study was to evaluate vitamin D status in children with type 1 diabetes mellitus and to correlate it with different clinical and laboratory parameters. So yes, I am done with my presentation.
That was really nice, Vivekhan. I'd just like a small follow-up here. When you mentioned that anything above 7 HbA1c is considered to be in the diabetic or pre-diabetic range, actually
Yes.
the current guidelines is by the American Diabetes Association, the ADA guidelines. You have to like either make a note of it or at least, I mean, I don't know if that image you put was standardized, but according to the criteria, I hope you're aware the fasting blood glucose greater
It's
than
around
126.
6.5%.
Exactly. So HbA1c is greater than or equal to 6.5%, or
Yes,
a random blood glucose greater than 200, to 2-hour postprandial greater than 200, and or fasting greater than 126. So that's like the standard. And have you read about any studies that would differentiate the diagnostic criteria in type 1 and type 2 diabetes? Is there anything particular that you have read about in general? Because I know
no.
this paper is focused on mainly type 1
Type 1.
diabetes, but that's what. So normally when you're diagnosing a diabetic, you use the ADA guidelines, right? So is there, if there is anything, then just let us know later on, like if there's any particular level of differentiation. Because as far I know, the only differentiation is that in type 1 diabetes, as we know, it's more autoimmune related. So you have the GAD antibodies, islet cell autoantigen, and antibody against the zinc transporter 8. These are the criteria. These are one of the options which are available in type 1, but the diagnostic criteria, according to me, remains the same. If anyone else is aware of it, then it'd be nice if you guys can share it.
Excuse
I
me.
think Rohan raised his hand. Yeah, Malavika.
Yes, so actually there was one study that I came across. So it was a small pilot study. So over here they compared the vitamin D levels in type 1 and type 2 diabetes. So over here they showed like a higher prevalence of deficiency of vitamin D in type 2 compared to type 1, sir. And they also...
One second, you said higher prevalence of deficiency in type 2 compared to type 1.
Yeah.
And that was just one study. And the other studies, and including this follow-up studies, compared it with type 1 diabetes. Or this is, was type 1 studied with vitamin D after the type 2 diabetes was concluded to have vitamin D deficiency, or was it the reverse?
So it was done at the same time. Like they took, a small number of patients who had type 1 and another set who had type 2 and compared.
Okay, that way. And any other data which, this article states what? Is it more with respect to type 1 or lesser? Is it positively correlated, negatively correlated?
Sir, it's negatively correlated.
All right.
Yeah, and one more thing is that there were like 2-3 more studies that kind of extended it to like BMI, age, sex, and like also insulin treatment. So there were like a few other studies that just extended these things.
So when a lot of studies, a lot of highly published studies, when they compare all these age, BMI, standardization, when they have multiple demographics, so in a lot of articles, the first section would be demographics. So what they usually do, they use the demographic is to see, is there any variation with age and this particular factor? So does age become a confounding for your hypothesis? So if you're hypothesizing that vitamin D deficiency, as you said in that other paper, has type 2 more compared to type 1. So that is your hypothesis. That was the author's hypothesis at that moment. When we do demographics, you're actually trying to see if any of the demographic factor falls as a confounding factor. For example, let's say a lot of articles in cancers, they do age below and above 65. So let's say in your study, in this particular study, that when you're comparing vitamin D to type 1, is it more significant under 65 or above 65? You get what I'm trying to say? So these demographics are mainly for that particular aspect. They don't do it to create a direct comparison, but to assess if it is a confounding variable in that analysis.
Okay, sir.
All right. Ma'am, Prerna ma'am, Nithya ma'am, do you all have anything? We can go ahead next.
Well, I think it was a very well presented topic, and I think it was quite well highlighted about how vitamin D is produced in the body, how it affects the immune autoimmune status in the body, and how that probably would be leading to the development of type 1 diabetes mellitus. So we'll go on to see what the statistics also suggest now. Thank you so much, Vivekhan.
Thank you, ma'am.
So shall I start with the statistics?
Yeah, sure. You can start, Malavika.
Yeah. I'll just share my screen. Oh, just let me know if everyone can see the screen once.
Yeah, we can see it.
Thank you. So, good evening, everyone. I'll be talking about the methodology and statistical analysis in this research paper. So, firstly, the study type is a prospective analysis. So, basically, prospective implies that we're looking forward to something in the future. Retrospective would mean where the data was already collected and we're analyzing it after that. And secondly, it was conducted in the OPD of Department of Pediatrics in Navodaya Medical College and Hospital in Raichur, after which the test samples were sent to the Biochemistry Department of that medical college. And over here, they selected 100 participants. So these were all pediatric patients under the age group of 6 to 15 years, out of which 50 were control and 50 had type 1 diabetes mellitus according to the American Diabetic Association criteria. And over here, the fasting blood sugar and the postprandial blood sugar, they were collected in sodium fluoride EDTA tubes by drawing around 4 ml of peripheral venous blood. And the HbA1c samples were collected in dipotassium EDTA tubes. Now coming to the analysis of the components. So for the fasting and postprandial blood sugar, they used the God-POD method, that is the glucose oxidase peroxidase method. So over here what happens is that we have two enzymes, namely glucose oxidase and peroxidase. And after their reactions with glucose, we ultimately get a colored compound called red quinone, which is red in color, and the intensity of the color is directly proportional to the amount of glucose present in it. So this is determined colorimetrically through an autoanalyzer. Now, secondly, HbA1c, or the glycated hemoglobin, was analyzed through the ion exchange resin method. So how this works is that there are certain ion exchange resins which have a particular affinity to HbA1c. So only the hemoglobin molecules bound to the which are glycated or bound to glucose, only they attach to the ion exchange resin. So in this way, it's easy to separate it out. Thirdly, vitamin D was analyzed through enzyme-linked fluorescent assay, or alpha, which is very similar to ELISA, or enzyme-linked immunosorbent assay, except that alpha is around 100 times more accurate and precise. And that basically deals with the antigen-antibody interaction. So in this study, we had to divide people into groups. So first group division was based on the HbA1c. So under that, we had three subdivisions. Firstly, the good glycemic control, which had HbA1c less than or equal to 7%. Moderate glycemic control, which where the HbA1c varies between 7.1 to 9%, and poor glycemic control, where HbA1c is more than 9%. So, higher the HbA1c, we can observe that the glycemic control is poorer. And this is based on the ADA, or the American Diabetic Association criteria. Second type of group division was based on the vitamin D levels. So this was according to the National Health and Nutrition Examination Surveys conducted between 2003 to 2006. So this was based on a study conducted in India, where they had where they conducted a research for checking nutritional requirements and all that, and finally found some RDA values. So over here we had 4 subgroups. So group 1 was vitamin D levels less than 12 nanogram per ml. So over here they had severe deficiency of vitamin D. Group 2, where the vitamin D levels in the blood varied between 12.1 to 20 nanogram per ml. So that was considered to be deficient. Group 3 was 20.1 to 30, which was not deficiency but some sort of insufficiency. Group 4 is more than 30 nanogram per ml, and that is normal. Now coming to the inclusion and exclusion criteria in our study. So the inclusion criteria, so basically the study involved all the children in the hospital with type 1 diabetes mellitus in the age group of 6 to 15, and all the type 1 diabetes patients taken here were on insulin therapy. Secondly, the exclusion criteria. So as I said earlier, the age group was only between 6 to 15. So children less than 6 and greater than 15 were excluded from here. Secondly, vitamin D supplementation. So obviously we're calculating vitamin D levels, and supplementation can definitely increase it. So we won't get a clear picture for our study, and that's why we're excluding them. Now, nutritional rickets. Over here, there's a resorption of calcium, so which ultimately influences the vitamin D levels again. So therefore, even this group was under the exclusion criteria. Thirdly, malnutrition, liver diseases, and end-stage renal diseases. Even these 3 conditions influence the vitamin D levels in the blood, and therefore even they were under the exclusion criteria. So now we look at some tables which gives us an idea into the statistics. So over here, this is basically the characteristics of the studied groups. So as I had already mentioned, we had 50 normal patients and 50 patients with type 1 diabetes mellitus. So out of those 50, we had 8 patients who were deficient, 9 patients who had vitamin D insufficiency, and 33, and the others were like they had sufficient. Now, coming to the age, so in 6 to 10 years of age group, we had 24 controls, and 11 to 15, 26. So they were the normal individuals. With that, we had 24 males and 26 females. And the duration of type 1 diabetes mellitus was they were not very sure about that, because most of them manifested with the symptoms much later than they were actually having the type 1 diabetes mellitus. So this was not taken into consideration. Now HbA1c, we had like 50 of them, like since they're controlled, they had like totally good glycemic control, that is less than 7%. Now let's come to the type 1 diabetes mellitus cases. So over here, in the age of 6 to 10, we had 1 patient, and 11 to 15, we had 5 patients who had severe vitamin D deficiency. Similarly, in 6 to 10, again, we had 17, and in 11 to 15, we had 16 patients who had vitamin D deficiency. And in vitamin D insufficiency, we had 6 patients under the age group of 6 to 10 and 5 patients under the age group of 11 to 15. So I think you can just look at the gender-wise statistics as well. And coming to HbA1c, good control. We had 3 people from the vitamin D insufficiency group, and there was nobody from the severe vitamin D deficiency or vitamin D deficiency group, because most of these patients will mostly fall under poor control or might be moderate control. So coming to vitamin D deficiency, 11 of them had moderate control, while 22 of them had poor control. And severe vitamin D deficiency is mostly an indicator of poor glycemic control. So we had 5 patients, like all the 5 came under poor control. So now we have table number 2. where there's a comparison of mean levels of vitamin D, FBS, PPBS, and HbA1c in the controls and the people infected with T1DM. So, so what, like, if there's something like 10.8 plus or minus 2.83, like for people who are just starting like me, I just want to explain what this is. So this basically means that the age in years of the control group A can vary between 10.08 plus 2.83 to 10.08 minus 2.83. So it's basically the mean plus or minus the standard deviation. So the standard deviation is the maximum number by which it can vary in either sides from the mean value. So these are the statistics over here with all the values. You can have a look at them. But more significantly, we have the p-value, which is like obtained by an unpaired t-test. So over here, we had a software called SPPS 9.0. And that was basically used for performing the statistical analysis. And the statistical analysis was done by student unpaired t-test and one-way analysis of variance and Pearson's correlation, which I'll be talking further. So coming to the age in years, you can observe that the p-value is 0.067. So one thing that I like to tell is whenever the p-value is less than 0.05, it indicates that there is some significance. But whenever the p-value is less than 0.0001, that means it is highly significant. So it has some amount of value to our study. So over here, if you observe, age and years, we've got the p-value as 0.067, which is more than 0.05. Because of that, we're considering it as non-significant. So in other words, it can mean that the age and years is not it's not an essential factor to test the association between type 1 diabetes mellitus and vitamin D. So we can rule that out because...
Malavika, I'll just ask you one small question here. When you say that you mentioned that it is not significant and hence you can't create a correlation. Forget, we're not even talking about vitamin D right now. I'm just asking you have two groups. Okay, you have age in years as in group A 10 plus or minus 2 and in the group B you had 11 plus or minus 2. If the p-value had to be less than 0.05 or in this case since most of the data is in 0.001, what would you infer if I gave you the p-value as 0.03? In this case, what would you do?
In that case, I would infer that age in years is statistically significant over here, and that has a role to play. So basically, it can be over here since it's non-significant, even if the age is 0 or if the age is maybe 65 or 67, it'll almost give us the same inference. But then if it was significant, then there might have been a difference between a newborn, a child, and an old man, something like that. The age in years.
So there are two ways to interpret this. What your interpretation is a little different because there is something else to understand age with respect to your research question. If forget everything else, if in this table the age in control in group A and group B was significantly different. Look, we are not talking about the study right now. We are just talking age in group A versus group B. If that was significantly different, then the study would have a question that if the data is different between the age groups, then don't you think the study should have been done separately? So in this case, if let's say there is no significance, that means it's good. That means my group A, my controls are within the same range as my group B. So age will not be a confounding factor as of now. Had it been significantly different, then I would have had to assess my entire data in 2 or 3 different age groups. All right. But I cannot at all make a conclusion whether age would be a mandatory factor for type 1 diabetes and vitamin D. That whether it's significant or not, I cannot say it based on this p-value here. Over there, you do ANOVA, which is analysis of variance. When you do those, you can compare age with your research in question. But as of now, leaving all the other rows aside, if I'm just comparing the age between group A and group B, and I tell it to be significant, that means it would be different between both the groups. But if it's
Yes.
not significant, means it's good. That means I'm comparing similar standards of control and test. It's always better to conduct your research between similar age groups. Your control should always be within the similar, or there has to be some standardization with respect to your test group. So that is one small thing, a small interpretation which I wanted to share with you all.
Yes, sir. Thank you so much, sir.
Go ahead.
Hi, Malavika.
Yes, sir. Hello, sir.
Yeah, hi. In the beginning of this methods section, you said it is a prospective analytical study. Can you elaborate on that?
Yes.
Those are usually not technical names. What is prospective about this? And is it an accurate nomenclature? It's a very simple question.
So like prospective, like what I have understood is like usually studies are divided into prospective or retrospective. So prospective is something like you don't know what is going to happen, like you're just finding out that. But then retrospective is that the data has already been collected and you're like interpreting or looking back on that. So that's what I think it is, sir.
Yeah, that's very accurate. Yes. So prospectively, basically, you're waiting for something to happen. Yeah, you're going forward in time to see, to collect more data and then analyze and all that respective. That is good. Is this study a prospective study?
Yes, sir. Like they mentioned that it is a prospective study because
They mentioned that's not this one. What does it look like? At a particular point of time, they included 50 on one group, 50 on the other side.
Yeah.
And they're comparing the two groups. What does it look like? What is the research study? What is the study designed to be? They should have actually mentioned.
Is it case control study, sir? Like
no, case control, you have already outcome has happened, you go back in time to assess the risk factors. So what is this? It's like you're taking a section at one point of time.
Cross-sectional study.
Yes, it's a cross-sectional study. It's not a prospective. And usually it's best if you mention what actual research study design it is. Okay,
yes.
So that's about it. Yeah. So yeah, also probably a little bit advanced for your this one is a t-test. In this particular slide, you put an unpaired t-test.
Yes.
Is the t-test valid with such a small? You have 100 patients, 50 on either side. Is it good to use a t-test?
No, sir. I think we have to use ANOVA for that.
No, that's not. I'm actually telling what is the sample size, how does it impact, what sort of t-test to use, or do you use t-test at all?
Sir, I'm not very sure.
Yeah, okay, no worries. I think at this point, a t-test would not be it's good. You can go ahead.
Yeah, thank you so much.
One second. Vinay, I'm not sure with respect to your t-test and ANOVA thing. In this case, t-test would not be a problem because t-test is for a numerical means 2 groups, whereas ANOVA is for 3 or more groups. In this case,
no, ANOVA can also be for 2 groups. No one said 3. 3 you can do with ANOVA. 2 also you can do with ANOVA.
If okay,
let's say you're comparing height between 2 groups. Okay, so in one study you do 10, let's say 10 people versus 10 people from, let's say, Karnataka, some 10 people from Delhi, and you compare the heights. You do another test, another study, 100 people from Karnataka, 100 people from Delhi. You measure the heights, and you take let's say 1,000 people now. You measure from Karnataka, 1,000 people from that. Yeah. So let's say all of them show the same difference in heights. Which result would you more rely on?
I don't get the difference per se because frankly speaking, the way we've done stats is that if you have a numerical means to be compared and if you have exactly 2 groups, you follow up a t-test. But if you have 3 or more groups, it's ANOVA, according to what I know.
Usually for simpler this one, so you use an ANOVA. For 3 or more groups, two groups they tell you can use with a t-test, but t-test has more to do with how many participants you have in your study rather than the number of groups. So like I said in this example, if a difference in height exists, it's best to take the 1,000 versus 1,000 because it's more reliable, it's more representative of the populations within both. But if you take 10 people and 10 people on either side, whatever result difference you do get, it's not, you're probably going to be a little doubtful of your results. So that's why t-test
Correct, but that
is
is just talking about increase in sample size. That is increase in sample size.
That's what t-tests are for. T-tests are for comparing groups when your sample in each group is very low. That's what t-tests are particularly for.
Okay,
Very
just
small
another
sample
thing is for
sizes.
small sample size. Look, again, it comes to difference between what is the variable to be compared. If you're talking about numerical means, t-test does not, according to me, have a difference in the number, the sample size. If you're talking about categorical, yes, there is a difference. Okay. If you're talking about proportions, you can talk about small sample size. You can use the Fisher's test, large sample size, the chi-square test. That all you can do. It also uses the t and the p-value. But when you're coming to numerical, what I am aware of is this. If you have a reference, can you just put on
ANOVA
the
is just
page?
analysis of variance. It can be between 2
Correct.
groups, 3 groups, 4 groups, and so on. Anyway.
Graphically, 3 or more groups. But can you just put a reference on the group?
Yeah, definitely. Yeah, I'll put it up.
Thank you.
So, yeah. Malavika, I think you can go ahead.
Yes, sir. Thank you so much for your inputs. So now we have the table. Okay, I think. Yeah, sorry. In table number 2, I just wanted to continue that here vitamin D, FBS, PPBS, and HbA1c, since all these have p-value less than 0.0001 or equal to it, they're considered highly significant for our study. So they have some sort of correlation with our study. So now coming to table number 3. So over here we have the comparison of vitamin D levels in diabetic children with the laboratory parameter.
Malavika, just a small sorry for interrupting. Can you go back to the previous one? Just tell me your inference.
Sir, over here, since vitamin D, FBS, PPBS, and HbA1c, like they have p-value less than 0.0001, it means that like they're like highly significant. Yes.
Okay. I think there's a little bit of this one. Okay. See, you're comparing your controls versus your cases groups here. Okay, so your unpaired t-test is a type of t-test you use to compare two groups to see if they are different. If whatever the difference in values are seeing is significant, not just statistically significant, it's also clinically significant. Okay, so in the first one, you have age in years. You have a very small difference in age between those two groups. One is like 11.02, the other one is 10.08. So there is a difference in height, but that is not statistically significant because it is 0.067, it's about 0.05.
Yes.
So if you take the next value, let's say vitamin D, it's 34.16, the other group is 16.51. Very small amount of difference in vitamin D levels, but it is statistically significant because it's 0.001. So the bottom four, they are significantly different in values, numerically significantly different. Okay, so that's what basically you're coming. T-test is to compare two groups. It has nothing to do with correlation as such at this point.
Okay.
These tests are done to distinguish if two groups are actually different in these parameters.
Yes, sir. So, just a doubt. So, can I infer that there's a high significant decrease in the vitamin D levels and a high significant increase in FBS, PPBS, and HbA1c in the T1DM cases as compared to the controls? Can I infer something like that?
So what we can basically tell is that the FBS levels in type 1 diabetes mellitus is numerically significant. It's numerically significantly different, and also statistically significant. In the end, you can just add once you compare the two groups. In the end, you can just give a blanket, statistical significance. But each one of them are, according to the test, they are actually different.
Yes, sir. Yes, I understood it now, sir. Thank you so much.
You're welcome.
So now we have table number 3, where there's a comparison of vitamin D levels in diabetic children with the lab parameters. So over here, again, age in years. So for the age in years, we have divided it again into two groups, that is 6 to 10 and 11 to 15. So, and over here also, we've used the mean plus or minus the standard deviation. So you can just have a look at the values, and now we'll come to the p-value. So over here, the p-value is taken using one-way ANOVA, or the one-way analysis of variance test, as opposed to the previous one where we had taken unpaired t-test, and where we had controlled the controls and the type 1 diabetes mellitus cases. So over here, Also, we get to know that the age in years comes to be non-significant because it is 0.47, which is greater than 0.05. Now coming to the duration of type 1 diabetes mellitus, the p-value comes to be greater than 0.05 again at 0.134. So even here it comes to be non-significant. Now coming to fasting blood sugar, postprandial blood sugar and HbA1c. So all the three of them, they are significant, statistically significant because all of them have p-value less than 0.0001. So over here, the table 3 basically shows that severe vitamin D deficiency in type 1 diabetes mellitus patients had a high significantly elevated levels of fasting blood sugar, postprandial blood sugar, and HbA1c, followed by patients with vitamin E deficiency, and then followed by patients with insufficient vitamin D levels. Now coming to table number 4, we are seeing the correlation of fasting blood sugar, postprandial blood sugar, HbA1c and vitamin D in the children with type 1 diabetes mellitus. So here we come across something called Pearson's correlation. So I'll just give a brief about that. So Pearson's correlation basically is the correlation between two values. So it can range between -1 to +1, where -1 is the highest negative correlation or the highest inverse correlation, to +1, which is the highest positive correlation or the highest direct relation or direct proportionality. For example, like, studying is kind of directly proportional to the marks. So that is a positive correlation deviating to +1 because it is something that is directly proportional. But as opposed to studying and wasting time, I'm just giving a very crude example. So if it's studying and wasting time, it's something that is inversely proportional. Right. So that has a deviation towards -1. So that is what it means. So over here, we get to know, we're seeing the relation between fasting blood sugar, PPBS and HbA1c with the vitamin D levels. So coming to fasting blood sugar, the Pearson's correlation is -0.872, which is very close to -1. So over here we can infer that the fasting blood sugar is inversely proportional to the amount of vitamin D. So here fasting blood sugar is obviously raised because of the type 1 diabetes mellitus, and it was observed that there was a decrease in vitamin D levels. Similarly, for PPBS, we had Pearson's correlation -0.924 with the vitamin D levels, and HbA1c had again a negative correlation of -0.931 with the vitamin D levels. And p-value, as already mentioned previously, was less than 0.0001 for all the three. And therefore, as I had already said, it is statistically significant. So table 4, we can basically infer that there's a highly significant negative correlation between fasting blood sugar, postprandial blood sugar, HbA1c, and vitamin D levels in the type 1 diabetes mellitus cases, along with the p-value showing us that it is statistically significant. So this is it from my side. Next, I think Rohan
Malavika, a couple of questions. Just can you go back to the previous slide?
Yes, sir.
Yeah, just a small rule and not rule, but yeah, what is appreciated when you're describing data is don't just put it in terms of numbers and statistically significant. You have to explain the inference of that table, I would say. Yeah, because you said duration, you just pointed out the numbers and you pointed out to 0.134 and said not statistically significant. That is not usually an inference statement. Right? You're reading out data. You have to provide an inference statement. So let's say in this, let's take age, okay? So for the age of 6 to 10, let's say, the three groups have around 9, 8.88 and 9.50, okay?
Yes.
What you can infer from this is, although the ages are different between severe deficiency or or not, what is that, insufficiency or whatever. Whatever the deficiency you're seeing is not, it's just purely out of chance. This is not going to be influencing your, deficiency levels. You have to put it as sort of an inference, okay? And also, didn't they do any regression analysis for this paper? Because they've done a correlation, they have the variables for a regression. Because only a correlation was done. Can you tell a small difference between a correlation and a regression? I mean, if it's too difficult, that's fine.
Sir, I'm not sure about regression.
It's fine. It's fine. It's fine. It's just what this basically tells is the negative and positive are inversely related and directly related. What do the numbers tell at least? Okay, let's say from 0 to 1, irrespective of the sign, what do the numbers signify? Let's say.
So 0 is no correlation at all, and 1 is the highest correlation.
Divide it into a little bit more.
Yes, sir. So, yes, 0 is like no correlation at all between the
let's say on
two
a graph
things.
you plotted FBS versus 25 OH or 25 OH on the y-axis, FBS on the x-axis. What do those, let's say, and you did a scatter plot, basically plotted all 50 data points and you drew a line. Okay, so what does that 872 signify?
I don't think they're very well aware about all of this. I mean, they'll reach that point.
Okay, fine. Just a small answer is how close those points are to the line.
Yeah, I think she did mention. She mentioned the same thing theoretically rather than on a graph. She mentioned the same
correlation. This is because the difference between regression and correlation, not a lot of people understand. That's why regression gives you the strength of association. Regression just gives you the direction and how close. And correlation gives you the direction if it is directly or inversely proportional, and just the closeness of the points to the line. So let's say even if you have even a very strong, very vertical correlation line, but it has very dispersed, scattered points, so correlation will still end up with a very small value, even if it is, let's say, showing a very steep line or a very strong association. Yeah, it's the dispersion of those individual data points around the correlation line. That's what those 0 to 1 represents, and the negative is the sign, obviously.
Yes. Yes, sir. Thank you so much.
Thanks, Malavika. This was really well presented. I know it's quite difficult for you all to get the statistics and all, but as slowly as when you come to PSM and you get hold of more articles, you'll get a better idea of it. But thank you so much for your part. I think the next one can present.
Yes, sir. Even from my side, I would just like to thank everyone, especially Nithya ma'am, Pratik sir, Manini ma'am, Prerna ma'am, and even Vinay sir. He has really given a lot of insights, and I'll surely read about it, sir, once again. Thank you so much.
Yeah, good job, Malavika. I mean, I understand first years and all that, but you're picking up really well. That's very well presented.
Yeah, thank you so much. And thank you everyone for joining. Over to Rohan.
Hello. So this is Rohan Dubeer from first year BMCRI. Vivekhan, can you please present my slides? Yeah, thank you. So good evening, everyone. So I'll be discussing the discussion part of this research paper. Next slide. So first we'll look at the table number 1, which had characteristics of the studied groups. Yeah, next. In that, we can see that 22% of type 1 diabetes mellitus patients were 25-hydroxy vitamin D3 insufficient, 66 were deficient, 12% were severely deficient, and 18% of the controls were 25-hydroxy vitamin D3 insufficient, 16% were deficient, and 66 had sufficient levels. This indicates that there is a high prevalence of vitamin D3 deficiency in type 1 diabetes mellitus patients compared to controls, which is in agreement with this research paper. Yeah. In the present study, 25-OH-D3 levels were highly significantly decreased, and FBS, PPBS, and HbA1c levels were highly significantly increased in type 1 diabetes mellitus children as compared to controls. This is in agreement with this research paper. So, vitamin D deficiency is common due to several factors such as reduced cutaneous synthesis, due to religious practices, seasonal variation, fear of cancer, and practice of not taking the child out, increase in pigmentation, increased indoor lifestyles, use of sunscreens, decreased dietary intake, air pollution, increasing rate of exclusive breastfeeding, and low maternal vitamin D. Concerning 25-hydroxy vitamin D3 group B cases had a highly significant lower serum level than group A, that are controls. This could be due to beta islet cell destruction promoted by vitamin D deficiency in humans. This shows a strong connection between vitamin D deficiency and the incidence of type 1 diabetes mellitus, which explains low bone density in type 1 diabetes mellitus. This is in agreement with this research paper. So VDD leads to that vitamin D deficiency also leads to increased level of glucose and glycated hemoglobin, which is in agreement with this research paper. It has been estimated that there's a strong connection between vitamin D deficiency, the recurrence of symptoms of diabetes, and the complications of type 1 diabetes mellitus. It is therefore suggested that the vitamin D levels of the diabetic persons should be assessed on a regular basis. Vitamin D has a direct effect on beta islet cells, including improving insulin secretion and enhancing the expressions of vitamin D receptors. This is in agreement with this research paper. It is also found that 25-hydroxy vitamin D3 was lower in patients with type 1 diabetes mellitus compared with controls, whether newly diagnosed or after years of diagnosis. These findings may support the idea that vitamin D deficiency may be an important factor behind the development of type 1 diabetes mellitus due to immunological background. So severely vitamin D deficient type 1 diabetic mellitus patients had highly significant elevated levels of FBS, PPBS, and HbA1c, followed by the patients with vitamin D deficiency with insufficient vitamin D levels. This shows that there's a close relationship between reduced vitamin D3 levels and improper metabolic control among diabetics. So vitamin D supplementation during pregnancy decreased the risk of development of type 1 diabetic mellitus in newborns. Destruction of beta cells begins in infancy or childhood and continues until type 1 diabetes mellitus is diagnosed. So supplementation of vitamin D at an early age also decreases the risk of developing type 1 diabetes mellitus. This is in agreement with this research paper. Even after the onset of diabetes, it may improve glycemic control. Supplementation of vitamin D in pregnancy, lactation, and early childhood protects against or reduces the severity of pancreatic insulitis via the dual action of beta cells and immune cells. This is in agreement with these research papers. Next. So let's look at the conclusion part. So vitamin D deficiency is associated with and suggests a role in pathogenesis of type 1 diabetes mellitus. It acts as an immunomodulator which has good protection against pancreatic insulitis. Supplementation of vitamin D during pregnancy and early childhood decreases the risk of type 1 diabetes mellitus and improves glycemic control. So it is recommended that creating awareness to increase sunlight exposure and intake of vitamin D rich food at the community level and vitamin D food fortification program at the government level. Next. So thank you for allowing us to present. Special thanks for Science and Research Club, Pratik sir, Manini ma'am, everyone.
Thank you, Rohan. I think I really like this part where you mentioned about all the other articles. I think it was a very well done discussion where you mentioned about the article, its particular finding, and whether or not it was correlated to the article in question that you all are studying. I think that's really nice. Like whoever will or is going to be presenting posters or presentations in the future. That's a very key thing, that a discussion should be solely focused on what other findings are, and was it in correlation or not in correlation to your paper, and whether or not you have a theory or hypothesis in and around that fact.
Okay, sir.
I think we'll open up to other people and everyone who has questions and any discussions. So,
yes, sir.
Nithya ma'am, would you like to add something?
First thing I'd like to say is that all the three presenters, you did a really good job. As first year students, it's quite difficult for you to probably understand how important it is to get into the whole habit of reading papers. And even statistics, like what they pointed out, you haven't really done with your PSM postings. So unless you go there, you may not really be very familiar. But I'd also like to thank at this stage both of you, Pratik and Vinay, for really helping them understand the statistics as we went through them. Thank you so much for that. And the last part especially was quite nice, because as Pratik rightly pointed out, it is really important that whatever study we do, that we really help them understand whether it is in relation to what are the other studies, and if there are anything else that we may have to include, or if there is something else we should have considered during the study. And with that, I think even I would like to open this up for discussion, because if there's anything else that someone would like, probably then I can add some points here and there.
Yeah, thank you, ma'am. Anybody have anything to add?
Hey, Rohan. Yeah.
Yes, sir.
Very excellently done towards the last part. Okay. I'm going to keep a very basic question.
Okay.
Can you attribute causation to this? How much causation can you attribute, if at all? And if not, what would you do?
I
See if
didn't
there
get you,
is
sir,
it causes.
because
Now, towards
I
the
didn't get
end,
you,
what
sir.
sort of a result? Sorry. Okay. Towards the end, I mean, does vitamin D actually, through a direct causation,
Yes, sir.
the immunomodulation, immune factors, and type 1 diabetes? Does it cause?
Yes, sir.
Does it cause
Yes,
or
sir.
correlate?
Okay,
Because you
sir.
said the last line.
According to the research paper, what I've read and what I've understood, so I think that it is just the vitamin D is somehow preventing for the immune cells to act on the beta cells. Like that's essentially an immunomodulation.
No, that's what you see. You're finding two parallel things sort of behaving in the same pattern. Either in one decreases with the other, one increasing with the other.
Yes,
But
sir.
how much can you tell that it is causing that? One is causing the other. Does this experiment tell you that, or no? What is it exactly telling you? Even in the inference line, they didn't. Even in the you can read it in the last result line. They will tell you that.
The result, the conclusion, it says that like it acts as an immunomodulator, which has a good protection against pancreatic insulitis. That's what they've mentioned, sir.
All that is good, but that's what they are saying. They're attributing causation. They're telling that vitamin D is doing it.
Vinay, I don't think they're very familiar. Vinay, I don't think they're familiar with the terms. But Rohan, what he's trying to ask you in simple terms is, you said in this article about vitamin D and type 1 diabetes, right?
Yes.
So can I now finally conclude that because of change in vitamin D, there is type 1 diabetes? Can I say that first statement? That's my first question. Second is, if it is so, how much? All right, these are two things. Now, with this article, with the amount of data you are presented with, forget all the words, causation and all, you learn those words later on. But simply asking you, can I say that because of a change in vitamin D in the body, type 1 diabetes can occur? Or is it just a finding which these people have presented?
Okay, sir. So what I've understood is just a finding, and it's the other way around. Like people having type 1 diabetes mellitus are prone to vitamin D deficiency.
Yes, that's
so if I
a
can
good
add
answer.
to it, if I can add to it, so basically in type 1 diabetes mellitus, as Rohan pointed out, vitamin D deficiency is one of the major things which are seen in most of the patients, but however, it is not the only thing. It's not like vitamin D deficiency precipitates type 1 diabetes mellitus. There are various other factors like even viral infections or even chemicals can precipitate type 1 diabetes mellitus. And
Right. Right.
most
So
importantly, genetic factors are important. If the parents have it, the children have a higher probability of getting it.
That's good.
right.
That's a
So
very
this
good inference.
article,
Yes.
this article just tells you that I have found, we as authors have found this correlation. It could be
Yes.
incidental, it could be accurate, it could be inaccurate. And plus, it's a look, 100 patients is again very small when you compare on a global scale. You're talking
Okay,
about
sir.
in that particular area, you're talking about in that particular demographic group. So, as you said, Finland had a different set of data. Indian countries have different set. Western countries will have different sets. All these countries
Yes,
have
sir.
multiple analysis and sets of data. So that's why global studies or multi-centric trials are done. As Vivekanand said, it's not only vitamin D, and you cannot even
Yes,
say
sir.
it's major or minor as of now, Vivekanand. You can say that, yes, it is a possible factor. The only thing you have to assess is in the future is that what is the concordance, like how much of the factor does it play a role. That's why they say
Okay,
some
sir.
conditions like embryological conditions, they say it is multifactorial in origin, right? So
Yes, sir.
that is for you to know that this is possibly one finding, but there can be also a lot of confounding factors, a lot of things that we have overlooked, because here they're just blindly looking end to end. They're not seeing the in between path between that. Look, there are a lot of technical terms for this, but I'm not going to use them, because as first years, if you'll at least understand this much, y'all can actually get a good hold of the next paper y'all read.
Okay, sir.
Yes.
Yeah, exactly, Vivekhan. So good good inference. What you can basically say is, if I end up finding, the lot of if I end up having vitamin D deficiency, let's say in that particular age group, I can expect to find, an elevated sugars or elevated HbA1c. That's the best you can come up with this paper. It is just that if I
Yes,
find
sir.
this, probably I can find that also in this patient.
Yes, sir.
So that is one.
Yes,
Like
sir.
I said, yeah. How could you, let's say, assess the strength? I already told this a while ago. How would you say, like, how much, if, let's say, vitamin D varies, how much would your sugars vary? I told this while I was
It's inversely
during Malavika.
proportional.
No. How will, what test would you use? Let's say, if I vary my vitamin D by this much, my sugars will vary a certain much. I already told this to Malavika when I was telling her about correlations.
So is it about regression?
Yeah,
I
regression.
suppose.
Yeah, regression gives you the strength of association. Correlation,
Yes, sir.
like I said, it only gives you the dispersion of points around that line. Doesn't give you the strength. Even if, let's say, the strength is too much. If you take a scatter plot, you drew a line and it is showing a very steep slope. That's like even let's say it's just showing one. But the points of this one, if it is varying or dispersing too much around the line, your correlation will be very, very, very small. So it does not give
Okay.
the strength of association. Strength of association is given by regression. Okay.
Okay, sir.
What was wrong with that correlation table? Can anyone tell me? What is the dependent and independent factors here? What are you testing? What is this one you're telling that, I'm going to take this. I'm going to, that is a independent variable, and you're going to check something like, with respect to this, I'm going to see how the other one is varying.
So age was an independent variable is what I suppose?
No. The final correlation table, you only did correlation for vitamin D against the sugars, right?
Yes, sir.
Yes, sir.
Yeah, which is the dependent one in that, in the sense like, okay, what you have taken, that's going to stay constant, and what are you going to check if it is varying? Other years can also answer, please. Whoever is there, not just presenters.
Sir, I think sugar levels was constant and vitamin D was the sugar levels was the independent variable and vitamin D was the dependent.
We are taking, you chose all the patients with what kind? Do you take all type 1 diabetes patients or patients with vitamin D deficiency?
They've taken all with type 1 diabetes mellitus.
Taken all the type 1 diabetes mellitus, but what sort of way are you going? That's what I was a little worried about. Because you're saying that if vitamin D is present, I can expect this patient to have type 1 or confer protection of type 1 or any of that, right? if you're taking vitamin D levels to see if, how much the sugars are varying, right?
Yes, sir.
Yes, sir.
So the table should have been the other way around.
Vinay, could you just explain to them exactly independent and dependent variables briefly? No, it's not in detail, but just briefly.
Okay. So let's say I'll go with the basic explanation of heights. Okay. Fine. Now just let me come up with an example. Just give me a couple of seconds.
Meanwhile, Rohan, Vivekhan, and Malavika, do you all have any particular things you all want to address or discuss, or something which you all had doubts with, or something that came up during your reading? I mean, you guys would have read the paper multiple times, so anything that you all find in question, or we don't have all the answers to, but we'll at least figure out what other questions you all had while reading the paper.
Sir?
Yeah, Malavika.
Sir, so basically, one thing that we observe is that type 1 diabetes and comparing type 1 and type 2 diabetes, like it's often observed that type 2 diabetes, it shows a family history. But then type 1 diabetes mellitus is genetically inherited kind of thing. So like, can you just elaborate a bit on that?
Okay, so as you said, type 2 diabetes is more seen as what? Could you repeat that? Type 2 diabetes is seen what in more? What
so like type 1 diabetes mellitus, like it's based on a genetic.
Correct.
Yeah, just that. But then, like, if you observe the family history, usually type 2 diabetes mellitus is the one that shows a family history as opposed to type 1.
Okay, so that is the independent assessment of type 1 and type 2. The thing is, type 1 diabetes is more immunologically mediated, and if they have genetic etiology, it's usually with the HLA genes, right? Those HLA-DR3, 4, they increase the risk of developing. But as in the beginning of the presentation, he mentioned that type 2 diabetes is more prevalent than type 1 diabetes, right? So you are likely to see type 2 diabetes to run in families because of its sheer prevalence. Right. If you're going to see 1 or 2 type 1 diabetes patients, that's going to be very of a young age group. You're going to find obesity as a concern. And those are more, rarely seen. When you see type 2, it's very common, as you mentioned. Because of that, I think it's a bias of an observer like you, for example, have a bias that, yes, it's running in family and type 2 diabetes. But overall, the way I infer it is it also has an association. The clear-cut pathogenesis for genetic inheritance is more proven in type 1. And I'll just mention the factors. That was HLA, DR3, 4. And your immune factors are those antibody against the glutamic acid decarboxylase, islet cell autoantigen 512, and the zinc transporter. So this is proven. Hence, they say that if it is there in the family trait, it will pass down. But type 2 is not proven there is a correlation, as you said, that, it is seen in family, but there are no specific genes completely mentioned for that. So I think that would be a probable observer bias. That's what I think I would explain it that way.
Yes, sir. Thank you so much. Sir, I had one more doubt.
Yeah.
Basically, I read about maturity onset diabetes of young also, the MODI. So, I'm not exactly sure why it happens and how it just happens at that age. Because usually, if you see type 1, it's diagnosed at an early age, and we know the cause, it's genetic. Type 2, we know it's lifestyle. But can you just elaborate a bit on MODY also?
All right. So the thing is, before there was a very clear-cut classification: type 1, type 2, and other specific types of diabetes. But now there's actually no classification. The question that you've asked is quite important because a lot of researchers, a lot of programs have already worked on the same question. I cannot absolutely say that type 1 diabetes is inherited and type 2 is, lifestyle-based. Okay, there is a mix of both. It's like a Venn diagram. There can be inheritance in type 2, as you mentioned. There can be some environmental factors in type 1. For example, the factors that I am aware of for type 1 are the viral infections like Coxsackie, rubella, and enterovirus. They are likely to cause type 1 more often than type 2. So it's not a clear-cut differentiation. But when coming to MODY, maturity onset diabetes of young, when you've studied biochem in your first year, you've studied a lot of diseases with early age group presentation, like, for example, difference between autosomal and autosomal recessive and dominant inheritance. There are presentations which are earlier, right? So for example, AR presents earlier, AD presents later. So like that, in maturity onset diabetes of young, there are certain specific point gene mutations. Like, for example, HNF4 alpha is for MODY1, glucokinase is for MODY2, and HNF1 alpha is for MODY3. If I'm not wrong, this is it. What you do is, what happens in these conditions is these manifest much earlier. And it is just a incidental finding that because they are enzymes, they present earlier in life. Okay, so that's why they've classified as single gene defects of beta cell function, under which we have two categories. One is your MODY, and other is genetic mutations, other genetic mutations. So as I said, MODY 1, 2, 3 are these three, and genetic mutations are other. There are other neonatal diabetes, which presents earlier than 6 months, and other conditions like that. So those are incidental. They just found it easier to group it under one particular defect, right? So if you say type 1 diabetes, it has multiple possible antibodies and genes. But when I say MODY, it's just one single specific mutation for that kind of MODY1 or MODY2, and hence presents at that particular age group. Now, was that clear enough?
Yes, sir, it was very clear. Thank you so much.
Good. And just to like talk about like the classification wise, you have type 1, type 2, specific types, and gestational. In type 2, in the specific types, you have single gene defects, which is MODY and other genetic mutations causing neonatal diabetes. You can have exocrine pancreatic disease like pancreatitis, surgical resections, hemochromatosis, cystic fibrosis. Those are other conditions which can cause that. You can also have some genetic defects with respect to insulin action. And other endocrine disorders could also precipitate it. What is important for you all to also know, there are some drugs which also can lead to diabetes, like thiazides, pentamidine, diazoxides. They can cause hyperglycemic states and lead to diabetes, but those are more likely reversible. You stop the drug, you stop the problem. And then last is gestational diabetes. When you'll come to OBG, it's a completely separate topic to study. I hope that overall classification of diabetes is clear.
Yes, sir. I had a question. So, while I was reading the paper, they had given about the location of the genes, and when I was cross-checking it, it wasn't very clear. The answers were different in different websites, and as you had also told that the genetic basis is not very clear. So, if you get to know about it, please do share.
All right. So, just a small thing with that also. When you come over the years of MBBS, at least since I'm in final year, a lot of places, they say a lot of different associations. Some books will say HLA-DR 3 and 4. Some books will say D4 and 5, D2, D3. Some says D. Like, the thing is, every book has a different reference, okay? And that's why they say follow standard textbooks or follow standard guidelines, right? So, as I said, in type 1, you have those three, like the ones I remember is the GAD, ICA 512, and transzinc transporter. The most important among them is GAD, glutamic acid decarboxylase. In that, a lot of studies would have found it on this gene, on this chromosome, that chromosome, this the short arm, the long arm. So everyone has different ways of analyzing data or their research. It's just that over the years, let's say 1,000 scientists have worked on identifying the gene defect for type 1 diabetes. Today, as of now, what I will do as a researcher is I will go through all those 1,000 and see which one wins the vote, right? Which one has the maximum which one has been proved maximally. And then I will take that from my understanding and I will write it, or I will consider it in my routine clinical practice. That would be the way I interpret that.
Yes, sir. Thank you.
Sir, one more question. One more question I had while reading through the research paper. It gave that people like small children are suffering from vitamin D deficiency because they're not taken out for like reduced cutaneous synthesis is because of this. There was a point called fear of cancer. What was that, sir?
So this is not a very Indian concept per se. This concept applies to the Americans and the people at the polar regions, where we've studied that there are the ozone layer defects and ozone layer damage. Where, and in the first slide also you presented, if I'm not wrong, UVB causes activation of 7-dehydracholecalciferol.
Yes, sir.
When
Yes, sir.
UVB passes through, so I don't remember. I remember we did that in school, but UVB is not present at the areas where the ozone defects are present. So you have more of other toxic UV radiations which do not induce vitamin D deficient or vitamin D activation. Now, in those areas, those kind of ultraviolet rays have a higher propensity to cause malignancies. So let's say there's a family across the coast and they don't want to send their kids out too much because they're scared that the sun, which is very harmful in that area, can cause a risk of malignancy. So they are feared. So they will allow the child to play more hours indoor. So your exposure, non-nutrient exposure for vitamin D is very less. So there could be a possible correlation. It is not definitive. It is not 100%. But yes, it is a good possibility. Like that way. I think in the same study in your paper it mentions religious practices. For example,
Yes, sir.
some Muslim groups, they have to wear burqas no matter where, how, whatever they do, and that black does not, the color does not allow a rays and UV light to pass through most of the times. So that could be a possible factor too. These are all theories which you could justify by saying these statements. But definitely you can go look up articles. I'm sure there would be some studies across those areas where they would have actually proved it to be, but not applicable everywhere. Like this will not be applicable in darker countries like, darker skinned individuals like in Africans and Indians. It's a little more difficult to come to that diagnosis or conclusion. I think
sir.
Vinay wants to explain the dependent-independent variables, and then after that we'll end the meeting.
Yeah, hi. So, dependent variable, let's take an independent variable, let's say it's the cause in this condition. Let's take a small drug, okay? Let's say for a particular case, let's say insulin. And basically, what insulin does is it reduces sugar. Okay, let's say in type 1 diabetes, let's say with increasing amounts of insulin, you're trying to assess how much the glucose drops. So your insulin, the doses are not changing. Your dose is not dependent on your glucose level changing. Your glucose level dropping is dependent on your insulin dosages. So the insulin part is your dependent, which is going to be reducing the glucose, which is your dependent variable. Insulin is your independent and glucose is your dependent variable. So in this case, what you're trying to assess is vitamin D, whatever this much concentrations or whatever you're looking, how much of diabetes it's going to cause by measuring FBS or HbA1c and all that. So your vitamin D levels are going to be your independent level variables, and your FBS, HbA1c and all that are going to be your dependent variables, depending on how much this one is there. So the table, and basically, quite frankly, the whole paper should have gone the other way. I don't know why only towards the inference they told that vitamin D reduces, associated with lesser amounts of this one. The whole paper, it's technically should have been actually reversed. But yeah, towards the end, they just assess the correlation. So even if the table goes left and the other one comes to the right, like I said, it's not the strength of association, it's a measure of dispersion. So even if those two variables change on the table, you'll basically end up with the same correlation. P-values, I think it'll probably change a little. Yeah, that's it.
Yes. Thank you, sir.
And general, this one regarding presentations, Pratik, this one's meant to be a symposium, right? Not a journal club per se.
This particular meet is a journal club. Why symposium?
Okay. No, because they put symposium in the title for that.
Oh,
so
okay. I mean, look, the juniors are handling it. They're very new to this, but that's all right. Okay. Basically, for them to understand how to do it, and they've done a really good job. So I'm really happy.
Yeah. So journal club itself, a little bit of heads up as to maybe the general flow. Very good. Just make sure you put it in a bit more direct, tones. Direct speech, saying that this study aims to, assess the effect of this something on a different thing. Don't read out the title, and even authors and all that. Don't spend too much time and all of that. It is say the first author's name, add et al. From so and so universities or whatever. That's it. Or give a part of the main first author's university name. Abstract, I wouldn't recommend, putting it up on a slide. It usually introduces a little bit of, you'll start leaning towards one result or the other at the beginning itself. You sort of go into reading the manuscript with that mentality of, this is going to be associated with this or not going to be associated with it. Okay, and keep your presentations close to 20 minutes. That's it. Okay, yeah, I know first, yes, it's good that first you need to know how to present the paper, which is good. You guys did a very good job. But subsequent journal clubs, and particularly if seniors and all of them are presenting, make sure you keep your presentation very short to 20 minutes. Okay, don't spend too much time on background. And whenever describing your statistics or your results, give the inference. Don't read out the table. We already have the paper. You forwarded us the paper. We can read it. What you are supposed to do is give the inference of it. Okay, so that way you can just give whatever the highlight points are within 20 minutes, and the next 40 minutes are up for discussion. Okay,
to follow up
towards the
to
end
what
of the first year, that's why I told the
just
senior batches.
The thing is, I think throughout, since we're all just beginning through this and this process, I think what one thing should be incorporated in a UG journal club would be, you all should make the presenter should make the objectives very clear. What do you intend to discuss? Do you particularly want to focus on the results? Then we'll all, as listeners, as audience, focus on the results. If you want us to focus on the pathogen, so how the research question in this paper came into place, then we'll all focus on that. So it's your responsibility to guide us or take us in the direction you want to follow the paper with. So today what you've done is, first you did about the entire vitamin D, the analysis, how the mechanism is, and then came up to the research part, and then the statistics here and there, and then come back to the discussion. So what happens is the focus is diffuse. What you all should work on is, if you want to focus on vitamin D as a whole, type 1 diabetes as a whole, and if there is small amount of correlation, in the end we'll focus on the results. But as first years, you all should be like, yes, this is vitamin D, I know what it does, I know how this moves through, and with respect to that. So different batches, different years, everyone can take it their way, and it's a start, so it's a really good.
Yes. That's about it. Towards the end, I would recommend for, let's say, senior batches or those who are more well versed with research, describe the limitations of your study. If there are any, why we can rely on these results, why we cannot rely on all. It's more for the senior batches, and let's say who have done more papers. I think that you can incorporate into let's say the 10 minutes after the 20. Yeah, you need to explain can we rely on the results of this research paper? That's what the journal club is actually about. A paper is there. Can we rely on whatever it is saying towards the end? You report the results and tell, because of this so and so, results are not so reliable, or we can only restrict our findings to this part of it or this part of it. You have to be concise by the time you're finished with your presentation towards the end. So that's about it. That's about, I think we can go ahead. Pratik?
Yes, thank you so much, sir. These inputs we'll remember and put in our future presentations or journal clubs.
Thank you so much, Pratik sir, Vinay sir, Prerna ma'am, Nithya ma'am, and Mani ma'am for helping us with the entire thing. And I would like to thank the Science and Research Club as well. Thank you, everyone.
Thank you, Vivekhan, and thank you, Rohan. Thank you,
Fantastic job, you
really
guys. First years.
This is really good.
amazing.
Really good. Yeah, really good.
Yeah, you guys will get a certificate and all for you.
Mani boss will do all of that for you.
Yes. And you guys, your dedication, I heard Vivekhan stayed up till 2 or something yesterday, fixing up the animation, making the presentation. Amazing job. Thank you so much.
Thank you, ma'am.
Thanks for the interest. Thank you, Nithya ma'am, for joining us, and thank you for presiding over this meeting. It was really nice having you here.
Thank you so much for having it over. It was a nice learning experience for me as well. Thanks a lot.
Thank you, ma'am.
Yeah. Thank you.
So we'll adjourn the meeting, and hope to see you all soon next time. I think next one's going to be Prerna, and she's going to be presenting the new NEJM article on colorectal cancer. It's going to be a very fun topic, because I really want every one of you all to attend, because there's a lot of controversy on that paper. I will forward the tweet thread to you all, but it's a really interesting paper. If you all can read it, you all will come to know what lacunae even top journals like NEJM tend to make. So hope to see you all there next time. Bye guys, good night.
Bye. Rohan, you can end the